Okay, well, thank you all for joining us. I'm just going to open it up here with a little bit of an introduction. My colleague, Robert Popovian, Dr. Robert Popovian, is going to talk about a project we're very excited about related to the IRA. And, you know, the IRA has generated a lot of heat. There's a great deal of discussion about price controls and whether they're a good idea, whether it will diminish research, small molecule research, and all that research should continue to go on. Our project is going to try to get away from that a little bit. What we want to do is look at how the changes, and there were significant changes in the Part D program, how those changes will impact patients. And we're not going to have a pre-established narrative. We're going to let the data lead us to the conclusions. Are patients' out-of-pocket costs going to grow? Are Part D plans going to use utilization management more aggressively to steer? How are PBMs going to make up for potential loss of rebates under the price control program? We want to look at the data and draw our conclusions later, which is what we did with the 340B website. And Dr. Popovian is the ideal person to quarterback this project. He just published an academic article. Maybe he can cite it so people can read it, and it gives a whiff of kind of where we want to go on this project. And with that, I'm going to turn it over to him.
Thanks, Bill, and welcome everyone to the Pioneer Institute's briefing. So this is an exciting project that we're taking on. Maybe go to the first slide, Kato. So, you know, everybody knows about IRA and everybody has talked about IRA for the last several years. And there are some good parts and bad parts of Inflation Reduction Act for patients. You know, we take a look at the patient perspective. If you think about it, IRA basically created a cap for the first time in Part D program. We all know about it, $2,000. There's also a cap on how much they can increase premiums, which is caps at 6% for the baseline beneficiary plan. Elimination of the out-of-pocket costs for vaccines, leveling or smoothing, as they say, of out-of-pocket costs for patients over 12 months. Co-insurance will be based on the MFP price, which is a lower negotiated price. Risk transfer to the PBMs, which is a good thing. Bill and I always agree that they don't have enough risk and enough skin in the game, and that's going to happen now. And what they did is they codified insulin prices into law, which some manufacturers had already voluntarily done, but it's not codified into law. But what Bill mentioned is we're trying to create a tool, and this is where the negativity comes in, right? There's going to be reduced innovation for sure. We know that. I mean, CBO, all the way from CBO to our friends at Vital Transformations who have done a ton of work on this, has shown that there's going to be impact on innovation coming out. There's going to be also pressure on small molecule. Bill and I wrote a paper on small molecule actually development and the impact of IRA with regards to pain management. And there's no doubt there's going to be pressure on having less small molecules come out. There's more incentive for manufacturers to do large molecule development. The last 2 points is that there's going to be impact on launch prices because of this, you know, inflation protection, but more importantly, where our project is going, which is we think that there's going to be potential erosion of the benefit for seniors. And that's because primarily that PBMs are going to make less money. You know, there's going to be pressure, downward pressure on their profitability because of MFP. The margins are going to be smaller. They're going to have more risk. And I'll go through in more detail what we think. If you go to the next slide, this is something everybody knows about. This is the chart that was released by the government about the new prices with the MFP prices that came out. So I'm not going to dwell over it. There's 10 products that were reviewed, and there's going to be another couple of dozen products that are coming out end of February that are going to be listed. Next slide, please. As I mentioned, everybody agrees there's going to be impact on innovation. There's been a ton of work done on this. CBO has done analysis. Our friends at Vital Transformation, you know, have done a ton of work on this, but this is the impact of IRA, we think, from innovation that doesn't get as much attention. If you look at the right side, what you see is that there's going to be a shift into large molecule development. And this is an example of what Pfizer is going to do in the next 10 years. In large molecule development is going to shift from small molecules, which in oncology, to large molecules. And that's because of the incentives. There's better protection of 13 years versus 9 years. So to me, as an economist, this is a bad thing, because not only large molecules are more expensive to develop and manufacture and everything else, there's also costs associated with administering them. And inherently, they're more expensive just because of that reason. You need somebody to administer it either in a clinic or in an infusion center. So this is going to cost more money. We created an environment through IRA that we're just going to spend more money on drugs, unfortunately. Next slide. So IRA and PBMs, and this is where I was talking about that. Bill and I have talked a lot about this, and I know a lot of other people have too. There's going to be increased pressure on, PBMs from a profitability standpoint. There's going to be increased exposure. There's going to be inability to increase premiums, at least in the baseline plans. Rebate contracting profitability is going to dissipate, and something that basically we haven't talked about, but it's going to delve into our second area that we're going to update you all on, which is the 340B program. There's going to be less money for contract pharmacies, because if the MFP brings the price down and they're getting money based on, we know that they get their contracts based on the retail price of the medicine, they're going to make less money. So again, who owns these contract pharmacies? Primarily PBM. So there's going to be profit pressure on the PBM. So what can they do? So we know that first and foremost, they're going to go to the manufacturers and ask for more rebates, right? I mean, they're going to say, MFP is bringing down the retail price, the margins are lower, you need to give me more to make me whole. I don't know what the manufacturers are going to do, but my guess is that they're going to say no, because they're already giving upwards of sometimes 50, 60, 70% in rebates on some of these products. There's going to be, they're going to look at other product lines that they've traditionally stayed away from a rebate contracting standpoint. We know that they've already looked into vaccines. This is an area. And I wrote a paper through Global Healthy Living Foundation talking about that, how that's unnecessary. That's not going to help patients at all, because patients don't have any exposure in out-of-pocket in vaccines. Nobody does anymore through the passage of IRA, actually. So there is no benefit for patients. It's just to pad their bottom line. But primarily our concern, and this is where our tool comes in, the new tool that we're going to develop and introduce, and we're going to make it transparent, we believe that there's going to be some cost shifting for patients. So specifically related to some of these products that are being under negotiated, these MFP drugs, these negotiated drugs. So I'll go through how we're going to evaluate that, but that's the crux of our tool. Is that we're going to look at whether there are going to be changes in administrative burden, is there going to be more prior authorization step therapies, or there's going to be cost shifting. And what Bill said is that we're going to take it what the data takes us and display it publicly and transparently for people to make their own judgments. But we're hoping that this sort of lights a fire under CMS, who's supposed to be doing this evaluation. But I personally don't think they are going to be able to do it, because we'll show you some of the data. They really need to get deep into the data to be able to see the changes. And I'll go through it in the next few slides. Next slide, please. So as Bill alluded to, I just published a paper with my co-authors and Sador from the Global Healthy Living Foundation. It was published in the Journal of Health Economics and Outcomes Research. We looked at specifically on the two products that have MFP, the anticoagulant drugs, apixaban and rivaroxaban. Sorry, as a pharmacist, I should know that, right? How to say it. But what we did is that we said, okay, so these two products, and this is a modeling study that a lot of other people are doing too. Other folks are doing, not necessarily published in academic papers, but they're doing as work to see what's going on. So this modeling study was to estimate the potential cost impact if the patients are shifted from one tier to another. And then we looked at what the consequences of that will be for patient adherence and eventually patient outcomes. And the methodology we used, we actually acquired data, real data, utilization data and out-of-pocket cost data from IQVIA through a couple of the manufacturers that make those drugs. And what we did is that we used a surrogate, we said, what if the patients shift from a tier 3 to a tier 6? Because both of these products are in tier 3 right now, right? And how would that shift the out-of-pocket? And we were able to do that because we had actual data from those PBM, the 3 largest PBMs, CVS Caremark, ESI, as well as OptumRx, regarding how the shift happens. And I'll show you later on what we got and what we think our project that we're going to do with IRA is really going to shed some light on this. If you go to the next slide, Kate. So this was the results. I mean, it's again a modeling study, it's estimation, but we believe that the actual cost will increase between $235 to $482 million for patient out of pocket for apixaban and $105 to $206 for rivaroxaban. And what will happen is that patients' adherence will diminish. Patients are not going to be adherent, and there will be major cardiovascular events because of that, as patients stop taking their medicines. So the conclusion was really that we believe that CMS needs to do a hell of a good job to monitor this very closely. And they can't just sign off on formularies by looking at it on a high level. And I'll show you why we think that. If you go to the next slide. So this is the data that we got from IQVIA. A couple of things that you notice. First of all, there's a wide range of out-of-pocket costs for patients. It's not like everybody's paying $25 copay. You know, a percentage of patients are paying $0, but there's a lot of patients are paying $100 and above. In my opinion, what PBMs can easily do is shift these percentages of prescriptions from $0 to the higher amounts. And if you are CMS and you're just looking at whether or not there was a shift in the tiering, you're not going to see that. That means you need to go deep into the data and acquire this type of information to be able to do that. The other thing that we noticed is that they can move the tiers or they can add like administrative burden that we were going to follow. So our tool is going to do 3 things. If you go to the next slide, we're going to access MFP medications. We're going to look at the access for MFP medications, changing out-of-pocket costs. So what I showed you, we're going to look at percentage changes of prescriptions from 0 to all those copay amounts for the MFP drugs. We're going to look at change in formulary placement. That means tier placement. Are going to shift from tier 3 to a tier 6. I don't think PBMs have the chutzpah to do that. Honestly, I don't think they're going to do it, but I do think that they can shift the out-of-pocket cost subtly that nobody's going to notice on this. They basically look at this data, and that's what we're going to do. We're going to look at changes in the administrative burden. Again, I don't think they're going to do that because that's very transparent. If they all of a sudden are doing prior authorization or step therapy or quantum limits or even excluding the product from formulary, that's going to be too obvious. We're going to look at plan and PBM level changes. So we are in the midst of working with IQVIA to sign a contract with them to acquire data from them. So they're going to give us data for the 4 top PBMs in the country. And then we're going to get within those PBMs 8 plan level data. So we're not going to just have the PBM overall, but we're going to have the top 8 plans for each of those PBMs to take a look at. We're going to start the assessment in 4th quarter of 2024. All the way, we have right now a contract to go into the 3rd quarter of 2025. And we're going to launch the tool in 1st quarter of 2025 at this point. So we're happy to answer any questions that you may have about the tool, but we're very excited about it. We think that we can do a great job. We already have a tool that everybody uses. We were in a conference yesterday, Bill and I, and multiple people use our tool to be able to look at the 340B program. So we believe that this will be as good as the 340B to shed some light about it and really to keep CMS honest about what they need to do as an agency, because they are responsible for overseeing these formularies, not us, but we're going to basically push them into doing the right thing. So Bill, any thoughts?
What I like to emphasize is I think everybody assumes that once you price control all these popular drugs, patient access increases. We're skeptical about that. Yeah. We're not sure if patient access is going to increase because the PBMs are going to end up losing rebates and they're going to make up for that by raising out-of-pocket costs and doing other things. So we want to we're not going to reach a pre-conclusion about that, but
Yeah.
we want to look at the data and see if that actually is what happens. And
Yeah.
our guess is based on previous PBM behavior, that's what will happen. And patients will lose access, not gain access to these price control drugs. But anyway.
And our hope is to basically start with the 10, but then add the 25, and then add every year that the products increase and continuously monitor this. So on a quarter by quarter basis.
And again, we're hoping to shame CMS into looking at the data in a granular way.
Exactly.
Let's look at actually what changed in copays, not just what changed in tiers. And,
Yeah.
and we don't think tiers are going to change significantly, but copays are likely to change significantly.
Yeah. Any questions? Any questions in the chat? If somebody wants to raise their hand and ask.
Robert, do you think that they're gonna raise so they would just like raise the copay on their tier 3, all their tier 3 drugs, or just those tier 3?
No, it will be interesting. So that's what I was thinking this morning, actually. Eventually, this project has to evolve into looking at all like the top brand name drugs. It's not just the MFP drugs, to be honest with you, because what they can do is cost shift to a non-MFP drug. So eventually, I think, Bill, I haven't talked to you about that, but what we need to do is exactly what you said, Tom. Look at that issue. Because I personally think initially they're going to want more rebates. And manufacturers are going to say no. They're going to go through, try to get rebates off of other classes of drugs. And I think they're going to have a hard time justifying that to CMS of why they're putting a copay on a vaccine, for example, which should be zero copay by law, right? And then I think what they will do is initially try to play around with the MFP drugs, but eventually I think what you're alluding to is that they're going to probably cost shift to other things. What we can do technically with more resources, look at the top 100, for example, brand name drugs in Medicare and the top 100 generics, actually, which I think they may also do that, which is cost shift towards the generics, which we know they already do to a certain extent, you know.
But that would be a very robust project. And
right now, we have a limited budget. You know, we're starting out.
We could hire maybe CMS employees who wanted to continue to work from home, that kind of thing. You know, I don't know.
One follow on to that, I think this is very fascinating. I think it's going to be really helpful in sort of tracking all these changes.
Yeah.
But one like thought for consideration is maybe also tracking formulary exclusions. Obviously, we know with these 10 MFP drugs and future MFP drugs, they have to be included on formulary. And to your point, like with Clixpa, like not messing around too much with these 10, but it'd be interesting to see like, do we see other classes of drugs, not MFP drugs, excluded more? It's increase in formulary exclusion over sort of the baseline. We've been seeing increases. The data shows year over year, every year, going back some time now. So seeing how that kind of.
I mean, Josh, you already seen the premiums increase, right? Yeah. Double digit for the last 2 years in Medicare Part D. And that sort of like got washed over because the administration put $5 billion to support the premiums increases for the seniors. So you already see that happening, you know? Josh, I think what they will do personally, I'm not even sure. I think the percentages may shift here. But they can also do something else that we need better granular data to be able to identify, is that they may go, for example, you have a tier level of 50 to 100, right? And the average may be right now 75. They can go to 99, right? And nobody will notice. But so this is a starting point for us, we believe, that there's better, we need to get better data. And IQVIA has that data, by the way. We can acquire it from them. But Josh, I think that's the thing. I think there are going to be subtle changes that unless the CMS is really looking deep and granular level, like Bill said, there's no way they're going to see that on the level. And what's going to happen is 5 years from now, there's going to be some academic paper saying that out-of-pocket costs went up.
Yeah,
you know,
absolutely.
Right? And by that time, who cares?
Robert, just one question for you from the chat. We have a question asking, as patient advocates receive updates as you gather data for us, will that help us get better patient access legislation?
Yes, I think that patient advocacy, the provider groups, even policymakers who have an interest in this topic, this data will help them channel and get better educated of what's happening in these product lines that are supposedly being price controlled, you know. So this will allow them to have more transparent data, real-time data, rather than what we just talked about, which is like 5 years later, somebody publishes something that says, oh, well, we screwed up, you know? So our goal of Pioneer is be as transparent as possible. We've done it with 340B, and I think we can do it with this tool. Bill?
Okay, well, we're going to go to 340B now. It's a project that we're very proud of. It's made me an absent father. I've been invited to speak all over the country, and I'm just, we have a 340B tour going. But we created this web tool a couple of years ago, and it's been extremely valuable because, again, it's not a preset narrative. We're not reaching conclusions in advance of the data. People can go on and look at the data and draw their own conclusions. And so if you go on the pioneerinstitute.org website, when you hit the landing page, right in the center of the website, there'll be a 340B icon. You click on that, and this is what you'll get. You get 4 buckets of data. On the left, 340B program growth, and we're going to walk through each of these. And that just shows the number of hospitals, the number of pharmacies, and where they're located and how the program has grown in recent years. And there's some interesting data in there based on when HRSA made some policy changes. The second bucket of data is legislative mapping. And what we did is we looked at state legislative districts, both House and Senate. And the reason we chose state legislative district is because the state legislative districts, particularly the House districts, you can ascertain the poverty rate for those particular districts. And then using that poverty rate, you can decide whether 340B resources are misallocated. Like if a wealthy district has a lot of pharmacies and a lot of clinics and a lot of hospitals, that's probably not a good idea. It probably should be in a poorer area. So that's why we chose legislative districts, state legislative districts. The third bucket is hospital charity care. And we went out, at first, the charity care numbers that are most widely available are published by CMS and the IRS. And we looked at that data and we were skeptical because it's self-reported data by hospitals. So hospitals do things like they have a health fair, which is really for marketing, and they write it off as charity care data. So the CMS and IRS data is self-reported. The RAND Corporation has been tracking hospital charity care data for 20 years, and they have a detailed questionnaire with 1,800 questions that they send to every hospital in the country. And so we think that data is a little more reliable than the government's data. And so we purchased that data and put it up on the website. And then finally, the fourth bucket of data is we did Robert did a 50 state analysis of 340B and we looked at indicators like, are most of the contract pharmacies in this state in a wealthy neighborhood or in a poor neighborhood? And not surprisingly, many of them were in wealthier neighborhoods, but you can go on individual states and look at that analysis. Let's go to the next slide. And that's related to this first bucket of data, which is program growth. And this is a slide that shows contract pharmacies and where they're located. You know, hundreds, if not thousands in Texas and California. And then on the right, you'll see contract pharmacies for California only. And you can go on any state and see where the contract pharmacies are located. And in California, most, as one would expect, are in the state of California, but there are contract pharmacies in Florida, Texas, even Maine and Hawaii. And that's very curious. So you can track program growth and the growth in pharmacies and where they're located on our website. The next slide, please.
And you can do it based on hospital.
And you can do it based on hospital.
Or clinic or anything else that you want to look at.
So you can find out like where Mass General Hospital's contract pharmacies are located. And so the next bucket of data is legislative districts, and you'll see this is Michigan. And you can, on the right in the chart, you'll see poverty rate for the lower house districts in the state of Michigan. And then you can track, again, hospitals and pharmacies and clinics in that particular district. And it shows some very interesting data. Like in California, some of the wealthiest districts have a good deal of pharmacies and hospitals, and some of the poorest districts don't. So you can, there's interesting things you can do with this legislative district data. And this is the national numbers as far as contract pharmacies are concerned. And what it shows is that the 340B program is not being utilized by mom and pop pharmacies. It is Walmart and the big PBMs that have the vast majority of contracts. This is national data. And again, the top 3 or 4 are Walmart, then it goes to CVS Caremark, then it goes from there. So this is not, these pharmacies are big business and big for-profit business, and they're taking a substantial amount of money out of this program.
And this is why Bill and I think, because of IRA passage and the pressure on the pricing, the margins coming down, that PBM pharmacies are going to start hurting, because the way that they sign the contract, unlike traditional drug dispensing, which is a flat fee that most pharmacies get for dispensing medicines, we know from the contracts on 340B that they get a percentage of the retail price. And because of that, a $7,000 drug becomes like $1,100 profit for the pharmacy. So it's very lucrative business, and that's going to go down too because of IRA.
And here's what you'd find on our charity care page. Again, the national data is that the average charity care from a 340B hospital is a little over 2% of operating costs. And if you look on the right, you look at Massachusetts, and it's well below 2%. Now, in fairness, let me point out that the two, you may not be able to see this on your screen, but the 2 hospitals in Massachusetts that are number 1 in charity care one is Cambridge and Everett Hospital, and the second one is Boston Medical Center. These guys are doing good work on charity care. They're more than double the national average, and I've seen numbers where in some years they were 10, 11% of their operating costs went to charity care. So there are good actors in this space. I don't want to paint with too broad a brush, but in general, 340B hospitals are not keeping up as far as charity care is concerned. And one feature we want to add to the charity care is we want to understand where the charity care is going. So RAND Corporation actually tracks charity care that goes to the uninsured versus charity care that goes to the insured. And on the left is the chart, is the national data. And you'll see that the charity care, as one would expect, the majority of it is going to the uninsured. But in some hospitals, for example, Henry Ford Hospital in Michigan, you can see that more of the charity care is closely aligned with people who are insured. Not people who are uninsured. And people who are insured sometimes need charity care, but then that's an insurance problem. But generally, the 340B program was intended to go for the uninsured. And so this is interesting data we're going to add to the site. And I would be amiss if I didn't mention a report that just came out from the state of Minnesota. The state of Minnesota required its Department of Public Health to obtain the revenue numbers for 340B hospitals. How much money were they making from 340B? And this is data that doesn't really exist anywhere. So we were excited to see this report. It has its limitations, but it has some interesting data in it. Three drugs generated the most 340B revenue for hospitals. However, shockingly, the most commonly prescribed 340B drug in Minnesota was oxycodone, which is amazing. And this, not surprisingly, the state's largest hospitals benefited the most, accounting for over 500 million of the 630 million in revenue from the program. But let me say that number is a vast underestimation of the amount of revenue that hospitals are taking in, because 80% of the revenue for 340B comes from physician-administered drugs, not from retail pharmacy drugs. And what this data in Minnesota captures is only the retail pharmacy-filled prescriptions. So since 80% of the data comes from physician-administered drugs, and that's not included in this data, one could argue that the revenue from the 340B program, since retail prescriptions are 20% of the data, 100% of the data would be about 3.1 billion in revenue for the program.
And Bill, you want to mention the 120 million that goes to contract pharmacy?
Yeah, the next bullet is really important. 120 million of this revenue went to contract pharmacies. So this is an extremely lucrative business for the PBM-owned pharmacies in particular. And the largest recipient of 340B revenue in the entire state of Minnesota was the University of Minnesota Medical Center, which secured 129 million. And again, that's just in data from retail prescriptions. And according to the RAND Corporation, that hospital provided about $10 million in charity care. 129 million from retail prescriptions, 10 million in charity care. And the 129 million, again, is very low. You'd likely add 5 times to that because it doesn't capture the physician administered drugs. And here's, we took a sample of the reported revenues from 340B from some of the top hospitals in Minnesota and compared the charity care. And again, 129 million for University of Minnesota Medical Center, about 10 million in data. But if you go down the list, every hospital is securing more in revenue than they're spending on charity care. And this is one of the most, I think, disturbing conclusions about the 340B program.
Where does the balance go, basically?
Yeah, and we'll take questions on any of this, on the IRA or the 340B, and our contact information is there, so feel free to follow up with any questions via email or.
One question from the chat. They'd like to know if you could outline the degrees of freedom that PBMs have to alter out-of-pocket costs or copays independently.
They have significant, I mean, just within tiers, they can shift, right? And not only they can go from tier 3 to tier 4 to tier 5 to tier 6, or even whatever the tiering is, but within the tier, and that's the concern, that they can shift subtly and nobody's going to notice it unless they're looking at it like what we're going to do, which is looking at a very detailed level.
Unless you're a patient.
Well, unless you're a patient that you realize that
Then you're paying $100 and you used to pay $25.
$20, right? But again, I think what IRA did is fixed, supposedly fixed, but unless it has oversight, significant oversight, it can be abusive to the patients. So that's the concern that Bill and I have, and that's why we're doing this tool to make it more transparent. So almost keep CMS's feet to the fire to do the right thing.
And by definition, these MFP drugs are the most popular drugs that
Yep.
senior citizens are taking.
Exactly.
And so if they're going to be disadvantaged in accessing these drugs, that's problematic.
Yep. And the consequences are severe. I mean, you have drugs like for anticoagulants and cardiovascular disease. When you start screwing around with those drugs, you know, patient stops taking it, the consequences of having a heart attack or an MI or a stroke, you know.
Another question from online, wondering if you see a path forward or any potential solutions in light of the incoming administration or changes in Congress.
I think statutorily they're required to do. It's legislation that's been codified into law, unless they go back and try to reverse the legislation. Do they have enough votes to do that? I'm highly skeptical. I think this will move forward. I think they may put, the good part is they may put pressure on CMS or HHS to do more transparent, be more transparent about it. And then they may have, what we see and they see that patients are paying more and there's less access to the medicines, there may be an opportunity then to be able to go back to Congress and modify the bill, modify the legislation.
Yeah, and regarding 340B, the first Trump administration was well aware that Medicare was vastly overpaying for 340B drugs. You know, the hospitals were getting a huge discount, and then a Medicare patient would come in and they'd get ASP plus 6%, which is full reimbursement, and the hospital would pocket the spread. So the Trump administration proposed a lower reimbursement for 340B drugs specifically, and the American Hospital Association sued and successfully and blocked that. But I think the Trump administration is well aware of some of the problems of 340B.
Another question about the likelihood of other states' 340B data coming online, like what happened in Minnesota?
So we'll see. I mean, Bill and I met with a bunch of state legislators yesterday. Over maybe 60, 70 of them in the room. and we talked about it and we brought up the Minnesota data. So the question they asked us, so and by the way, there was a lot of awareness among state legislators about 340B. This was not some new gadget thing that they didn't understand. I think everybody, because it was sort of a breakout session, so anybody who was interested in the topic was in our session. And the question was, what do we do? And what we said to them is that, look, your states are we believe that every state is gonna have some type of activity with regards to 340B. 24 states did it this year. We anticipate almost all of them, 35 if not more, doing it next year. And we said, look, when they come to you, and there was a gentleman there from Oregon, because I testified in Oregon at the hearing, and he said, so what do we do? I said, look, what you can do is, first of all, don't sign on to these bills that say absolutely no transparency, right? That's number one. But number two, if you want to do something, do what Minnesota did, create a reporting scheme or mechanism to be able to then report to the state how much money they're making off of the 340B and be transparent about it. So we gave them a couple of options, not to sign on, or if they're doing it, do what Minnesota did.
Yeah, and it's always been our position at Pioneer that we shouldn't cut this program. That's
Yeah.
not the first thing that should
Absolutely.
happen, because there are some hospitals doing the right thing. I cited a couple in Massachusetts, but there are more. There are hospitals in Massachusetts I'm aware of that have 80% Medicaid, and Medicaid reimbursements are not market level. So they are sucking wind financially. And to pull out the 340B program from them would be a disaster. And you would have community hospitals closing because of that. And we don't want to see that happen. But the first thing that should happen is, like Minnesota, there should be some transparency.
Yeah.
How much money is this hospital taking in from 340B? And what exactly are they spending it on? And that's one of the deficiencies in the Minnesota report is they do point out revenue, although they ignore physician administered drugs, which is a significant non-admission. But they don't tell us where the hospitals are spending the money. And that's really an important part. And so if there's going to be transparency on the state level or even on the federal level, we think it should capture all the 340B revenue, and there should be some indication of where the money is being spent.
And by the way, just to clarify, I agree with Bill. I mean, we've looked at this data in every state, in every geography. And what you see constantly in every state is that the hospitals in poor neighborhoods that are really helping out patients are doing a good job. They give a lot of money back in charity care. They don't abuse the contract pharmacy issue. They have limited number of contract pharmacies. And it's the affluent hospitals and affluent neighborhoods that somehow or another got 340B designation because of either minimal Medicaid admissions, or in some cases, like we have a few large hospitals in urban settings that they got the designation due to being a rural hospital. And what we see is that they're the ones that have a lot of contract pharmacies. They don't do enough charity care. A lot of their contract pharmacies are out of state. And that's very much, whether you look at New York State, whether you look at Illinois or California, that's very constant.
And a lot of large hospitals affiliated with universities have the same problem. They're just very wealthy and they don't give out a lot of charity care.
Yeah.
A few questions online about how you envision the 340B tool being used and who is the ideal user. Bill, I know when you testified, a congressional member brought up using the tool himself. So if you want to tell maybe that.
Yeah, well, state legislators would obviously benefit from the tool because they can see the 340B resources in their state. But, even a patient could determine whether they're a 340B patient by looking at the hospitals and see if they're being treated at one of the 340B hospitals. And then they would know that their drugs are likely discounted by the hospital, and they maybe could ask for a discount themselves. And right now, there's some significant evidence that uninsured patients or patients that are paying cash because they're in the deductible phase are not getting the discounts passed on to them by the hospitals. They're paying full price, which is untenable to me.
Yeah, I think the tool is simple enough for anybody to use that has an interest in the topic.
And one final question from online, a question about the likelihood of a 340B rebate model moving forward for the 4 manufacturers that are currently in legal battles with HHS.
What do you think, Bill?
Well, I'm not a lawyer. I'm not a lawyer, but it seems to me that they have a good case. There's a lot of inappropriate, if not illegal, things going on in contract pharmacies. And, these manufacturers simply asking, can you demonstrate that this indeed is a 340B patient and they're eligible for a 340B prescription? That's it. I'm not sure how the courts turn that down. That seems reasonable to me.
No, I agree. I mean, for case transparency, we've talked to all the manufacturers that are involved in this discussion, including the organizations that are going to be the clearinghouse for this initiative. And frankly, it's a rebate model that's been around a long time. I mean, Bill and I worked with the Calderos' ex-CEO for a long time when we were developing actually the tool. And this is nothing new. It's been out for a while. And I think there's going to be impetus to do this for 340B, but also the IRA puts even more of a bullseye on this issue because now they're required to make sure that the MFP drugs are not dually dipping. Medicare wants to keep those rebates. They don't want it to go to a 340B rebate system to the hospital. So and by law, the manufacturers are required to make sure that doesn't happen. So they have a good case, I think.
Yeah, and I'll be a make-believe lawyer. There's nothing in the statute that prevents the rebate model from being enacted. It just says the manufacturers have to give a discount and a rebate is a discount. So we'll see how the courts decide it.
A couple more questions from online about the Minnesota report. Were you surprised by 80% of the 340B revenue coming from physician-administered drugs? Do you think that's true in other states?
Yeah, I do think it's true in other states because the biggest therapeutic area for 340B revenue is oncology. The average oncology drug now, new oncology drug, has a list price of about $200,000. So if a 340B hospital can buy that drug for $50,000, they can potentially pocket $100,000 or more in the spread. So there are certain therapeutic areas, rheumatology is another one, where the spreads are enormous between the 340B price and the way and how they would get reimbursed. And many of those drugs are physician administered.
A question about if it would be possible to see a top 10 list of the hospitals that are good for 340B and the same that are bad or abusing 340B.
Yeah, we can do that. I mean, we have the data to be able to cut it. It's just a matter of looking at it from different ways. And one of the other things that the new tool, we've updated the entire website, is that people are going to be able to scroll much more easier and simpler to do it. And then Bill and I have sat down with our data folks, Michael Walker, who does all our data work for us. And we did initially, I mean, when we got the access to the RAND Corporation, as Bill alluded to, it's like 1,800 questions that they ask these hospitals. So we have a ton of data that we're combing through to see what else is interesting to put out on the website for people to do compare and contrast. So
it's a program that 340B is desperate for reform. I mean, there are tens of billions of dollars in profits going to hospitals and clinics that treat low-income patients, and the money's not finding their way to these patients. It's almost as if the government required food wholesalers to sell their food cheaply to supermarkets, right? Without requiring that the discounts that they give to the supermarkets be passed on to the consumers. And so it's a very problematic program. The statute was written very sloppily, if I could say that, and it is desperately in need of reform, and these resources need to be redeployed.
And it's detrimental from a provider. I'm a pharmacist myself, but if you look at it from a community provider perspective, this is detrimental to them, because what this program does is make the PBM pharmacies and the retail chain drugstores a lot of money, and same with large hospitals. And what ends up happening is that these large hospitals then buy up independent physicians, and we've seen this with the oncology practices, and same thing is happening with the independent pharmacies. That's why they're closing. When you have more revenue and more leverage, you go then buy those independent pharmacies, and we already see a lot of pharmacy desert, just like physician practice desert in the communities.
A question about how your presentations for state legislators have been going. What have you found to be the most effective messages to get them to take action on transparency?
Well, I can tell you, I was involved in few of them. One was Oregon, and the Oregon bill got killed because what I brought up to the committee. And all I said is that your largest institution in your state, which is Oregon Health Sciences University, has over 100 contract pharmacies. 40% of them are out of state. Can they explain why they need so many out-of-state pharmacies for Oregon Health Sciences University? Why is their pharmacies not in the poor neighborhoods and they're in the wealthy neighborhoods? And can they tell us exactly what their contracting scheme is with these contract pharmacies? And they couldn't answer. This was a committee hearing that they testified also. And the committee chair turned around and asked OHSU to explain all this, and they couldn't answer. I don't think they have a good idea of what they have. Because what Bill and I, when we talk to the CEOs of some of these hospitals, they're just signing this contract willy-nilly. You know, I don't think they have a good understanding of what they're doing. I mean, they know they're making money, but I don't think they understand how vast and how many contracts they've signed with pharmacies and how many of them are out of state and everything else that they've signed with.
And the level of knowledge for state legislators is, as you would expect for a federal program, is less than members of Congress. I was quite impressed with members of Congress's knowledge of the program and the ins and outs and how it's gone off mission. I think the goal with state legislators is just to enlighten them about how the program has gone off mission. It's not serving low-income uninsured people as much as it should be. It's serving wealthier communities, in part because you need fully insured people to pocket the spread. Hospitals can't pocket the spread unless they get the fully insured people to come in the door. And so the program has drifted off mission. And if that message gets through to state legislators, then they're not as eager to go ahead and try to expand the program or support the program in some way.
And I mean, look, the only thing we can ask them, I mean, to sign on to a bill that says less transparency just doesn't make sense to us. You know, that doesn't make sense. And that's what we asked them yesterday when we were talking to the state legislature, like, don't sign on to it. Doesn't make sense. You want less transparency or more transparency?
California just adopted a measure, and I noticed that that didn't go through the legislature.
They went through a ballot initiative, so they, for a state that does everything wrong, they did something right.
Even a blind squirrel finds a nut.
I know, not once in a while. They had a ballot initiative, which was casted as a rent control. It wasn't even about 340B, but it requires that any revenue that comes from 340B be spent at least on healthcare services. You know, which is a good thing. And I think the reason it passed is because it was not cast as a healthcare ballot. It was cast as a rent control initiative. Which when you read it, I have no idea how it came up to rent control, but that's how it was promoted. Let's put it this way, and it passed.
A question about whether or not the tool includes data on community health centers as well.
Yes, it does.
Yes, it does.
Yes.
We haven't focused as much on community health centers only because as a general rule, they're better actors in the 340B space. They're required to give a certain amount of charity care, to pass on certain discounts, and they get audited. And so they generally have behaved better. Or there's some that are bringing in fully insured patients and trying to arbitrage the discounts. Yes, there's certainly some. But as a general matter, I think they've done a better job than the hospitals.
Questions about other patient groups that are starting to get involved in this work?
On the 340B, or I think we've worked with, Global Healthy Living Foundation, definitely Patient Rising. Bill and I just spoke at a meeting, so there are patient groups involved.
Yeah, and the patient groups are most concerned about not getting access to the discounts.
Yeah.
And that's, if you're uninsured and you're a patient and you're on an oncology drug, you want as deep a discount as you can get.
Any questions from folks in the room?
Well, my concluding thing is that you've seen the 340B tool. You know what we're capable of doing at Pioneer to really shed light on a very important issue. We're embarking on this IRA tool. So if you guys have, Bill and I don't have all the answers, and we want to hear from you, especially manufacturers, policymakers, anybody who's interested in the topic. Reach out to us about the IRA tool that we're developing. As I said, we don't have all the answers, but we believe that more transparency is better, and we want to keep CMS's feet to the fire. So we welcome anybody who wants to reach out to us and talk to us about it, has ideas of how to look at the data and everything else, so.
Yeah, for manufacturers, for example, we're going to buy the data on out-of-pocket costs from IQVIA.
Mhm.
You know, manufacturers, can you double check that for us and make sure that
Exactly.
that's accurate,
Yeah.
that the copays have gone up or gone down? And, you know, that's the kind of thing where we could use your help.
Exactly. So, Bill, you want to conclude? or-
No, it's, thank you all for joining us today. And hopefully it was enlightening about our research projects, and hopefully it's exciting to you. It's exciting to us. And we look forward to working with everybody.
Yes. Thank you.